Just published May 12, 2026, the American Urological Association and Society of Urologic Oncology's newest guideline update on advanced prostate cancer. This guideline update incorporates newly published literature related to the evaluation and management of advanced prostate cancer to facilitate clinical decision-making, including disease stages ranging from prostate-specific antigen or PSA recurrence after local therapy to metastatic disease. In today's rapid update, we'll just be going over a summary of new and updated recommendations. So for the full guideline, make sure to check it out on guidelinescentral.com. Let's get started. Starting with a section on early evaluation and counseling, germline testing should be offered to all patients with advanced prostate cancer. Somatic tumor testing should be offered to those with metastatic disease. Next, the section on biochemical recurrence without metastatic disease after exhaustion of local treatment options, specifically the section on prognosis. Periodic imaging evaluations should be performed for patients at higher risk of metastasis after PSA recurrence following local therapy, with preference for prostate-specific membrane antigen positron emission tomography or PSMA-PET and or computed tomography or CT, magnetic resonance imaging or MRI, and technetium bone scan. PSMA-PET imaging should be used in patients with PSA recurrence following local therapy. Now the section on treatment, patients with rising PSA after local therapy and no demonstrated metastatic disease should be risk stratified as low or high risk. Routine initiation of androgen deprivation therapy or ADT is not recommended in low-risk patients with biochemical recurrence after local therapy. Moving on to the section on metastatic hormone-sensitive prostate cancer, specifically the section on prognosis. Clinicians should assess metastatic disease extent in newly diagnosed metastatic hormone-sensitive prostate cancer or MHSPC patients and stratify based on low versus high volume. A baseline PSA and serial PSAs should be obtained every 3 to 6 months after ADT is initiated in MHSPC patients with consideration of periodic imaging. Now for the section on treatment, most patients with MHSPC should be offered androgen pathway directed therapy in addition to ADT. Select patients with MHSPC should be offered ADT combined with docetaxel and either abiraterone acetate plus prednisone or darolutamide. For select MHSPC patients that have homologous recombination repair or HRR gene alterations, clinicians may consider combining ADT with abiraterone and niraparib. Next, the section on treatment for metastatic castration-resistant prostate cancer. Patients who have not received prior androgen receptor pathway inhibitors or ARPIs and who are progressing to metastatic castration-resistant prostate cancer or MCRPC should be offered continued ADT with abiraterone acetate plus prednisone or enzalutamide. Docetaxel should be offered to MCRPC patients who are progressing after ARPI treatment. Clinicians should offer LU-PSMA-617 to patients with MCRPC with disease progression after ARPI treatment and positive PSMA PET/CT. Cabazitaxel may be considered to patients with MCRPC who've received docetaxel chemotherapy. Cabazitaxel is recommended over an alternative androgen pathway inhibitor for MCRPC patients previously treated with docetaxel and an androgen pathway inhibitor. Select patients with deleterious germline or somatic HRR gene mutated MCRPC may be offered a poly-ADP ribose polymerase PARP inhibitor. A PARP inhibitor combined with an ARPI may be offered to select patients with deleterious germline or somatic HRR gene mutated MCRPC. And there you have it. Make sure to check out the full guideline from the American Urological Association and Society of Urologic Oncology and other related clinical decision support tools at guidelinescentral.com.